السلام عليكم. أنا دكتور وائل عطية. النهاردة هشرح لكم congenital cyanotic heart diseases. First of all, let's define cyanosis. Cyanosis is bluish discoloration of skin and mucous membranes, where the saturation of a patient is less than 85% by pulse oximetry. If it's only present in the extremities, we call it peripheral cyanosis. If I can detect it all over the body, especially in assessment of the tongues, then it is central cyanosis. It's important to know how to elicit cyanosis. At first, I need to diagnose cyanosis in neonates as soon as possible. And it's very essential that we know that the dark complexion can affect the evaluation of cyanosis. So I need to check the tip of the tongues. Good lighting is important. I need to check in a thermoneutral environment because cold temperature of the room may cause peripheral constriction and peripheral cyanosis. If the child is poorly perfused due to hypoxia or hypotension, may also cause peripheral cyanosis. If I'm doubtful about the saturation of a patient, I need to check with a pulse oximeter or get an arterial blood gas to assess. Usually, a newborn in room air has a saturation of 92 or above, and oxygen tension in the blood gas sample should be more than 60 millimeter mercury. So what are the causes of neonatal cyanosis? First of all, CNS depression. Like in cases of perinatal asphyxia and heavy maternal sedation and intrauterine fetal distress. This is characterized by the baby is having shallow, irregular respiration with poor muscle tone. This cyanosis is correctable when the patient is stimulated or oxygen is administered. Pulmonary diseases of cyanosis includes parenchymal lung diseases like hyaline membrane disease, pleural diseases like pneumothorax or pleural effusion, chest wall diseases, and diseases of the muscle like diaphragmatic hernia. These are characterized by tachypnea and respiratory distress with abnormal breath sounds on auscultation. Chest X-ray may usually reveal the cause. Oxygen administration may improve or abolish cyanosis. Finally, cardiac causes of neonatal cyanosis include cyanotic heart diseases with right to left shunt. Usually there is tachypnea without retractions. There is a lack of abnormal breath sounds unless congestive heart failure occurs. Usually, if heart murmurs are absent, it's a serious form of cyanotic heart disease because usually we have the murmur of a PDA. Chest ray film may cause cardiomegaly and abnormal cardiac silhouettes, increased or decreased pulmonary vascular markings, and in blood gases there is minimal or maybe no increase in oxygen tension. What should I do to assess a case of neonatal cyanosis? First of all, we'll do a chest X-ray to differentiate between pulmonary and cardiac causes. Second, we can do an ABG or a hyperoxia test. It can also help to differentiate cardiac from pulmonary causes. Then I should do a septic screen and a blood glucose assessment because sepsis, hypoglycemia, polycythemia also can present by cyanosis. Finally, I can do an ECG and echocardiogram, which can show the causes, cardiac causes, and can assess also primary pulmonary hypertension of the neonate. What's a hyperoxia test? When cyanosis is confirmed by obtaining an arterial blood gas and the PO2 is less than 60, we can differentiate between the respiratory and cardiac causes of cyanosis by this test. We should administer oxygen at a high concentration, up to 100% to a head box. Then I'll obtain a blood gas arterial from the right radial artery and wait for 15 minutes to repeat the arterial blood gases. If PO2 improves to more than 250, then it's a respiratory cause. If it's still less than 150, it's a cardiac cause. When a patient comes to my clinic, before referring to a cardiologist, I should do the following investigations. Chest X-ray differentiate between reduced pulmonary blood flow and increased pulmonary blood flow. Then, with an ECG showing the different chamber enlargement, I may be directed towards some diagnosis before sending to a cardiologist. So, right ventricular hypertrophy with reduced pulmonary blood flow may be in cases of fallow. Left ventricular hypertrophy with pulmonary atresia with decreased pulmonary flow may appear in pulmonary or tricuspid atresia. Biventricular hypertrophy in reduced pulmonary blood flow may represent in TGE and truncus. Right ventricular hypertrophy in increased flow is diagnostic of total anomalous pulmonary venous drainage, or also in TGE with overflow, especially if I have a VSD or a PDE. Here are some common congenital cyanotic heart diseases. So, diseases with increased pulmonary vascular flow, like TGA, TGA and VSD, double outlet right ventricle, TGA, subpulmonic VSD, which we call Taussig-Bing anomaly, total anomalous pulmonary venous drainage, truncus arteriosus, single ventricle without a pulmonary stenosis. Then we have congenital cyanotics with decreased pulmonary blood flow, like total tetralogy of Fallot, double outlet right ventricle with pulmonary stenosis, Epstein anomaly, pulmonary atresia, tricuspid atresia, TGA-PS, and single ventricle in presence of pulmonary stenosis.